Hello and welcome. I am Dr. Sanjay Aggarwal, your ENT faculty and educator. And in this YouTube session, we are going to talk about some clinical based ENT questions. You all know that this is the era where they have started asking a lot of clinical based questions, whether it is the MCI screening test or NEET PG or other central board examinations. And that's why I thought that I'll take up clinical based ENT questions from ear, nose, and throat, all the three parts. This is part 1 of that series where I'm going to take questions only from ear today. In the next series, part 2 of YouTube, I'm going to take questions from throat and nose. So please watch out for that also. Now, once again, this is my name, Dr. Sanjay Aggarwal. And before I start, let me tell you about few courses that you know. This is NEET PG for 2022. It has already started, where we are teaching all the 19 subjects. And ENT starts on the 14th of December and will complete on 26th of January 2021, where we are going to teach ENT in 30 hours. And everybody knows about this iconic subscription where you get a combo of Unacademy subscription plus an app. And there are various packages in this. You can look at the website and you can choose what you wish to. And then we have this marathon batch for MCQs targeted towards NEET PG 2021. In again 19 subjects. ENT we have 5 hours, 1 hour each for 5 days, 5 sessions, starting on the 30th of November. So very useful for people who wants to write this NEET PG 2021 or want to revise NEET PG 2021. So with this brief background, we are going to start with the questions. And like I said, most of them are image-based questions. Clinical based questions. Now this is your first question. A school teacher during his summer vacation, student during his summer vacation had joined a swimming class. After 2 weeks, he has left ear pain and scanty discharge from the ear. There is no significant deafness, tinnitus or vertigo, no history of ear trauma or foreign body in the ear. Vitals are stable. Otoscopy shows a congested external auditory canal. EAC stands for external auditory canal skin with discharge, but the tympanic membrane is normal. No obvious swelling or growth in the canal, of course. Blood counts are raised with increased neutrophils. Most likely diagnosis. Localized otitis externa or furunculosis. Diffuse otitis externa. Malignant otitis externa. Exostosis of the ear. So with this history and finding, what do you think is the correct answer? Few seconds I will always give after end of each question so that you can decide what answer you want to mark. Now the answer is diffuse otitis externa. See, very clearly the culprit is swimming. The student joined swimming classes and the problem started after that. We all know that when you start swimming, go into the dirty water, the swimming pools all have dirty waters. This water enters the ear and this causes infection in the canal. Usually the entire canal gets infected, skin of the canal gets infected, and that's why it's called diffuse otitis externa. And as you can see, after it takes some time for infection, after 2 weeks he had pain. So it's an inflammatory disease, pain, and discharge which is not too much. Scanty means very little discharge from the ear. And because the middle ear tympanic membrane are normal, there is no vertigo, tinnitus or deafness, no trauma and foreign body. And otoscopy shows congested external auditory canal with discharge. But tympanic membrane is normal. That tells us that the middle ear is normal. It is only the external ear that has some inflammatory disease, and the cause of the inflammation is swimming. And because the water goes inside the whole canal, that's why the whole canal skin or a large part of the canal skin gets infected, and that's why the term diffuse otitis externa is used. I'm sure you understand this is also called swimmer's ear. swimmer's ear because it is due to swimming that the patient joined, also sometimes called Singapore ear. These are some of the terms that are used in this patient. Localized otitis externa is opposite of diffuse. Localized, as we understand, diffuse is the opposite term. Localized is a very localized infection. Only one hair follicle in the canal is infected, and the inflammation of the hair follicle is called furunclosis. And this is usually due to trauma or handling of the canal. When the patient uses stick or to handle the canal, then one or two hair follicle gets infected, and that's a very localized kind of a thing. In this case, we have tragal sign and all that. I'm sure you know that tragal sign, and this is caused by Staph aureus. But when the dirty water goes inside, like in swimming pool or when somebody goes for a holiday in the beachside holiday, then the entire canal skin gets infected, and there's more diffuse kind of a disease. And this diffuse otitis externa, which is swimmer's ear, is either caused by Pseudomonas, which is a more common pathogen, or sometimes Staph aureus also. Both are possible. Malignant otitis externa, on the other hand, the third choice, is seen in elderly person who are diabetic. So this is a student, young student, no diabetic, no elderly. And malignant otitis externa is more profound kind of a disease where pain is more severe. It is at the night time, and there's a very important finding in this case, which is granulations in the canal. All this is not given, so obviously this age is why it's not this malignant otitis, because the age is a young child, not elderly. There's no diabetes, there's no granulations, all these are not there, so it is unlikely to be a malignant otitis externa. And exostosis is a swelling in the bone of the canal. It's a swelling in the bone of the canal. It is seen in surfers, people who go for surfing, and that's why it's also called surfer's ear. People who go for white water surfing or cold water surfing, when that cold water goes inside, that causes a swelling on the bone and the canal gets occluded, and that's called exostosis of the ear. So it may sound very similar, swimmer's ear and surfer's ear. These two terms may sound very similar, and we tend to get confused, and both are due to water. See, swimmer's ear is due to water from the swimming pool, which is a dirty water, and surfer's ear is water from the in surfing, cold water. It's the cold water surfing. So if you do a surfing in the warm areas like near the equator, then you don't have this problem. And when you're surfing in the colder water in northern hemisphere or the southern hemisphere, then that water goes in the canal and causes this exostosis, and therefore it's called surfer's ear. White water surfers have this kind of a problem. So don't get confused with these terminologies. And diffuse otitis externa, swimmer's ear, because it's a widespread infection of the canal, so predominantly you have to give antibiotics, and also symptomatic for pain, or if there's a fever, pyretic and all that, and sometimes local drops are added, and you keep the ear dry again and again. You have to dry the ear with a cotton again and again, and that should be it. So treatment is not very difficult. But if it is Pseudomonas, I told you that diffuse otitis externa can be caused either by Pseudomonas or Staph aureus. Both are possible. But Staph aureus is much easier to treat, but if it's Pseudomonas, we all know it is slightly more resistant, and therefore you have to be more careful about the antibiotic that you give. You have to give anti-pseudomonal antibiotics, cephalosporins, penicillins, and ciprofloxacin, and all that. That's why in this patient, one of the very important thing is that we take a swab from the canal and send it for culture and sensitivity. So culture will tell us whether it is Staph or Pseudomonas, and sensitivity will tell us which is the best antibiotic you have to select for this patient, so that the results are better, the outcome is faster and better. So this is always advised in the, like in the previous one, localized otitis externa is almost always Staph aureus, so you don't have to really depend on culture and sensitivity to start your treatment. Whereas in this one, because there are two different pathogens and they can respond differently to the antibiotic, that's why this culture and sensitivity in this kind of patient becomes more important compared to the first or the third one. In third one, again, we know that if it is malignant otitis externa, then again it is Pseudomonas almost always. So you don't have to really depend on your sensitivity and culture. Is that clear? So simple question, but it's a very important concept-based questions. Let's go to the next one. An 8-year-old child is brought with hearing loss for few weeks. No pain, tinnitus, vertigo, fever, There is a history of ear pain and fever a few months back. That time the child was treated with antibiotics and painkillers. Now on otoscopy, tympanic membrane is dull, mild retraction of the tympanic membrane is seen. Audiometry is suggestive of conductive hearing loss, no other positive finding which is true of this child. Now first you have to make a diagnosis, and then the most common pathogen is Streptococcus pneumonia. This is the commonest cause of deafness in children. Laryngotomy is the best treatment. All are true. So obviously with this history and the finding, we'll first have to make a diagnosis and then maybe arrive at a correct answer. So it's a child who has hearing loss as the only complaint. There's no other complaint for few weeks, but there's no pain, no tinnitus, no vertigo, no fever. The patient has a past history a month back of pain with fever, ear pain with fever, but no discharge again. That time the child received antibiotics and painkillers, nothing else. So this is a past history now. So when a child has pain, this past history, pain with fever, pain in the ear fever, and see a small child may not complain of hearing loss. This child must have had hearing loss also. See, hearing loss does not mean the hearing is gone. When we say hearing loss, it doesn't mean the hearing is gone. Hearing loss or deafness means the hearing has reduced a little bit, 10%, 15% reduced. And therefore small children like 8-year-old children may not be able to appreciate if the hearing loss is very little. So that's why in the past there was no hearing loss. So most probably this child was suffering from acute otitis media. Acute otitis media. Why acute? Short history and pain. Pain, fever is an inflammatory disease. Acute otitis externa. In acute otitis externa media, which is usually due to blockade of the station tube. The station tube gets blocked due to congestion. We all know the station tube opens in the nasopharynx. So when somebody has congestion of the nasopharynx like nasopharyngitis, rhinitis, sinusitis, pharyngitis, tonsillitis, all these conditions, they cause congestion of the station tube and the tube gets blocked. When the station tube gets blocked, it is not able to function properly, and this causes acute otitis media. So one of the things that you have to do is that you have to open the tube along with antibiotic of course and the painkillers that was done in the past. The patient should have had received nasal decongestants like nasal drops, xylometazoline, oxymetazoline, because these will decongest the tube and open the tube. And if the tube opens, then the station tube starts functioning properly. But that decongestion was not given in this patient, as you can see from the history. That's why the tube remained closed, but the pathogen got killed in the middle ear because antibiotic was given. And that's why this fluid that collected in the middle ear, because the station tube was blocked, the fluid started collecting in the middle ear. It was not draining, and that fluid caused the problem of hearing loss. Now there's a fluid in the middle ear, and that causes hearing loss. So there's only problem is fluid in the middle ear because the station tube has not been opened in the previous problem. That was few months back, 1 month back. That's why there's no pain, because it's not an inflammatory disease, no tinnitus, no vertigo, nothing. Okay, and look at the finding. The finding is dull tympanic. Dull means loss of cone of light, no cone of light. Now when there is light and mild retraction, tympanic membrane is retracted. Now when the tympanic membrane gets retracted, the first change that happens on the membrane is this cone of light is lost, which is also here. And both these findings are very, very strongly suggestive of serous otitis media. Serous otitis media. So this child now is suffering from serous otitis media, which is due to incomplete treatment of otitis media with acute otitis media. And this is a very common sequel. This is a very, very common sequel that people who have acute otitis media and they don't get treated completely or properly, in other words, when the station tube is not open due to nasal decongestion, whatever, then afterwards, few months back, they lead into serous otitis media. The fluid collects, the sterile fluid. It is a sterile fluid because the antibiotic was given, so pathogen got killed, and the fluid remains in the middle ear. And now the condition is called serous otitis media, and a typical finding is retracted tympanic membrane. There are the findings also, like foreshortened handle of malleus, reduced mobility of the tympanic membrane, prominent lateral process, and dull color tympanic membrane as is given here. So a lot of findings, only two are given here, dull membrane and retracted tympanic membrane. But this is sufficient to understand that the patient had acute otitis media, which is followed by serous otitis media, which is like a complication of acute otitis media now. And obviously, in both these conditions, whether it is acute otitis media or serous otitis media, both will give rise to conductive hearing loss. So that's uh, obvious now, and there is no other positive finding. So basically, they're asking you that in serous otitis media, which of the following is true? Now, serous otitis media is a sterile fluid. I just told you in the middle ear because of antibiotics that was given. So fluid is sterile, and serous otitis media always has sterile fluid in the middle ear. So if you aspirate the fluid and send for culture, it is not going to grow anything. There's going to be no pathogen. So first sentence is not true, right? But second sentence is the correct answer. Serous otitis media is the commonest cause of hearing loss in children. This is also a very important MCQ otherwise. Very commonly asked, which is the most common cause of hearing loss in children. Serous otitis media is the most common cause of hearing loss in children is a very commonly asked question. So please be mindful of that fact. And myringotomy is done for ASOM, second half of ASOM. In serous otitis media, myringotomy with grommet insertion with adenoidectomy. So if they say with grommet with adenoidectomy, then it becomes a treatment for glue ear or serous otitis media. But in this particular choice, these two names are not given, therefore it is not a correct answer, and therefore all cannot be correct. So B is the correct answer, and this is a very typical of this is a very typical history in a serous otitis media, so you should be aware of this. And I'll tell you, out of all the types of otitis media that we have, acute otitis media, serous otitis media, tubercular otitis media, chronic otitis media, serous otitis media is the one that they ask you, this one that we have talked about, is the most important disease that gets asked in the exam. So please be mindful of this factor. So read this topic very, very carefully, and the finding especially, because the finding is the giveaway, like dull tympanic membrane retracted. And I told you other findings like foreshortened handle of malleus, prominent lateral process, reduced mobility of the tympanic. All these are very, very important findings, and air bubbles inside the middle ear and all that. Sometimes they can give you image-based question. Usually they give you a tympanic membrane with air bubbles inside. So straight away it is serous otitis media. So also look at the images of the finding of tympanic membrane in this patient. Correct. Let's go to the third one. A 32-year-old teacher presented with bleeding from left ear. She has been having continuous but scanty otorrhea for the past few months, for which she was taking medication off and on. No other complaints. Otoscopy shows perforation in the upper part of the tympanic membrane through which blood, few drops of blood was trickling. Due to this, nothing else was visible. Because of the blood, nothing else was visible. Vitals are normal. Renes in this ear is negative with webers lateralized to the same ear. The patient is prescribed few investigation, and in the meanwhile, the otologist began planning for surgery, which is the best surgery for this patient. Again, you have to make a diagnosis, and then you have to know which is the treatment of choice, which is the best surgery for this condition. So we'll talk about the explanation, but before that, what do you think is the correct answer in this patient? Is it MRM, modified radical mastectomy, simple mastectomy, myringoplasty, or tympanoplasty? Which is the best treatment in this patient? So what is your correct answer? Your clock is ticking. I'm waiting for your answers. And the correct answer is A, MRM, modified radical mastectomy. Now this is adult, doesn't matter the profession in this case, present with bleeding. Now bleeding from the ear can be vascular tumors, malignancies, trauma, and very important, unsafe CSO. Bleeding is also very common in unsafe CSO. Besides vascular tumor, malignancies, trauma in the ear, all that. There is no history of trauma actually, so that can be ruled out. Now she has been having continuous but scanty otorrhea, ear discharge. So she has a past history of ear discharge, which was scanty means very little but non-stop, continuous. And this is another very significant feature of unsafe CSO, aticoantral disease, in other words, for the past few. So it's a long history. That's why it is chronic suppurative otitis media of the unsafe type. And because he is having continuous ear discharge, she used to take medication off and off. That means she was not very serious about her treatment. That's why it is still persisting. So this first sentence tells us that she was having CSUM. Now we don't know it is safe or unsafe, most probably because she was having continuous and scanty discharge. This is very typical of unsafe CSUM. And because the discharge is very little, scanty, the patients are usually not bothered. That's why they don't take a proper treatment. They take medicines off and on, and that's why it is still progressive. And now she started having bleeding. Now if you have a ear discharge for some time and starts bleeding, that's another very important suggestion that the patient might be having unsafe CSUM. But in tumor of the ear also you can have a similar finding, but in tumor then it is very fast progressive, there's weight loss and all that, which is not given here. But the clincher is the finding on otoscopy. There's a perforation, so it tells you it is CSUM. Perforation is a very important finding in chronic supraorbital otitis media in the upper part of the tympanic. Upper part is which part? Pars flaccida. This is pars flaccida. We all know the upper part of the tympanic is called pars flaccida. And if you have a perforation in the pars flaccida, it is called attic perforation. This perforation is called attic perforation. So this patient is having an attic perforation. And attic perforation is a diagnostic of unsafe CSUM. So all these findings, all the three things, that bleeding from the ear, scanty continuous discharge, and attic perforation, all the three tells you it is unsafe CSUM. And nothing else is visible, doesn't matter. You still already know that this is a patient of unsafe CSUM. That's why it is conductive hearing loss. In conductive hearing loss, the release is negative and web-based is lateral to the same side. So this proves that this patient is having conductive hearing loss. But this does not give away much to the diagnosis, because all the middle ear disease will cause, whether it is ASUM, glue ear, CSUM, safe, unsafe, tumors, otosclerosis, any middle ear disease will have the same finding of tuning fork. So that's just an additional thing. It is not adding. So it's like asking what is the treatment of choice for unsafe CSUM. And treatment of choice for unsafe CSUM is modified radical mastoidectomy. MRM, I'm sure you know, it stands for modified radical mastoidectomy. MRM. Okay. Simple mastoidectomy is done usually for acute mastoiditis and also for glue ear that does not respond to the treatment. Myringoplasty is done for safe CSUM. Myringoplasty and tympanoplasty both are done for safe CSUM, but this is unsafe CSUM. So modified radical mastoidectomy. Safe CSUM has no bleed. The discharge is not scanty, it is copious. The term we use is copious. Copious means too much, and is non-continuous. Like in this it was continuous. In safe CSUM it is non-continuous discharge, no bleed, and perforation in pars flaccida, not in pars tensa, not in pars flaccida. So these are the features of safe CSUM. In this patient, this becomes the treatment of choice, myringoplasty. So you have to be careful about these things. All right. Next one, question number 4. Now, very similar question. A 30-year-old teacher presented with bleeding from left ear. She has been having continuous but scanty otorrhea from the past few months, for which she was taking medication off and on. No other complaint. Otoscopy shows perforation in the upper part of the tympanic vein through which few drops of. So the initial history I've given you the same because I was lazy, so I copied and pasted. But you already know from this much that she is having unsafe CSUM. This much you know already from our past discussion. But here on the question changes. Now release in this ear is positive with web-based lateral to the opposite side. On pressing the tragus, the patient was experiencing vertigo. The patient is prescribed few investigations, and in the meanwhile, the otolaryngologist began planning for surgery. Which is the best surgery for this patient? MRM, radical mastoidectomy, myringoplasty, and tympanoplasty. So very similar choices again. So see, it's a very similar question, just very subtle difference in the tuning fork finding only is there, plus there is an added finding of pressing the tragus causes vertigo. Now, we know it is unsafe CSUM already from the history, first paragraph. This because we have discussed, so I'm not going to waste my time again or your time again. But the Rinne's finding is positive and Weber's is lateralized to the other side. Now this tells you, both this finding tells you it is sensory neural hearing loss. See, unsafe CSUM is a middle ear disease which is causing sensory neural hearing loss. Why should a middle ear disease cause sensory neural hearing loss? Obviously there is a complication. Otherwise middle ear disease CSUM unsafe. Why it's called unsafe? Unsafe is called unsafe because it has a tendency to cause sensory neural hearing loss. So this has caused sensory neural hearing loss. That's why this patient is having because this patient is having complications. That's why this condition is called unsafe CSUM. And it is proven by the fact that this patient is having sensory neural hearing loss. How do we know sensory neural hearing loss? Because of the tuning fork finding. But there's one more finding which says that on pressing the tragus, the patient was experiencing vertigo. This is true positive fistula test. This is true positive fistula sign or test. So unsafe CSUM patient having true positive fistula test and sensory neural hearing loss means that the patient CSUM unsafe has complicated to become labyrinthine fistula. That's why there is a true positive fistula test. Fistula will give you fistula test, and because there is sensory neural hearing loss, some amount of labyrinthitis has also happened. Labyrinthitis is also happening. That's why there is a sensory neural hearing. Inner ear also affected somewhat because of the complication. So this is what is happening to this patient because of unsafe CSUM, right? And therefore, for unsafe CSUM, we all know MRM is the treatment of choice. But you know, if you have to do a surgery for unsafe CSUM, which is the best surgery? The best surgery is radical mastectomy. Radical, the word means that it is an extreme surgery of the mastoid. It's the biggest surgery of the mastoid. And because it is unsafe CSUM, we don't want to take any chance. We want to remove all the disease so that there is no complication. So we want to do the biggest mastoid surgery. Radical mastoidectomy is the best option. But the problem with radical mastoidectomy is that in radical mastoidectomy, you have to remove all the ossicles and the membrane also. So the disease gets removed. That's a very nice thing. But the hearing is very, very poor after this surgery. The patient nearly cannot hear anything. Now for you it's a good surgery because you have been able to remove the entire disease, although the hearing is not good. But think from the patient's point of view. Patient will make an assessment from the hearing. Patient does not know all these things. Patient thinks that I can't hear through the ear even after the surgery. In fact, after the surgery, my hearing has become even worse than before the surgery. So patient starts doubting the result of the surgery. Patient starts thinking maybe my surgery has gone wrong. Maybe the doctor was not that good. And the patient is always complaining about this. And to preserve the hearing also, that so that the patient does not have too much of hearing loss, we compromise on the radical mastoidectomy. We modify it a little bit so that the hearing is still preserved, and that's why the term is called modified radical mastoidectomy. So modified radical mastoidectomy is a modification of the radical mastoidectomy. It is actually a compromise. We are compromising so that the patient's hearing remains also satisfactory, so that the patient after the surgery is not going to complain, is happy that my disease is gone and I also can hear sufficiently well from my ear. But if the patient's hearing is already gone, sensory neural hearing loss, that means you can't improve this. Sensory neural hearing loss cannot be improved with surgery or medicines, usually cannot. So if the patient already has a hearing loss which cannot be improved, might as well as do the best surgery for unsafe CSUM. Which is the best surgery for unsafe CSUM? Radical mastoidectomy is the best surgery for unsafe CSUM, right? That's why in this patient, MRM is not the correct answer. In this patient, radical mastoidectomy is the better answer. Now, I gave you these two questions together, the previous and this one, almost same thing. The only difference was this patient has sensory neural hearing loss as a complication of unsafe CSUM, and that was because of labyrinthine fistula, which was proven by true positive fistula test, and the treatment changed completely. So once again, I'm repeating the same thing for your benefit. Unsafe CSOM is called unsafe because it is a dangerous disease. If you leave behind the disease, it can cause complications, and we don't want that. And that's why whenever you do a surgery on such a patient, you ensure that the entire disease gets removed. And if you want to remove the entire disease so that nothing is left behind, there is going to be no complication in future, radical mastodectomy is the best option, is the best surgery. But the problem with radical mastodectomy is that the hearing of the patient after the surgery is not very good, it's not satisfactory. And so the patient is never happy with the outcome of the surgery. That's why we modify this surgery. We in fact compromise in this surgery, and we do what is called modified radical mastodectomy in these patients usually, so that the disease gets removed and we try to preserve the hearing also. So patient has both removal of disease and some hearing preservation, so patient is satisfied post surgery. So this is what we do in most of the patient, modified radical mastodectomy, and this becomes the treatment of choice for unsafe CSOM. So if they ask you what is the treatment of choice for unsafe CSOM, we say modified radical mastodectomy is the treatment of choice. Why are we doing modified radical mastodectomy and not radical? Because we want to preserve the hearing of the patient. But when the patient's hearing is already gone because of this disease, due to sensory neural hearing loss, due to complication like in this patient, due to labyrinthitis, labyrinthine fistula, then you can't preserve the hearing. You can't give the hearing. So there is no use of modifying or compromising on the surgery. So might as well give the best surgery that removes the entire disease, so that there is no chance of leaving behind any problem. There is no chance of future complication, and therefore in such patients it is always better to do radical mastodectomy. That's why radical mastodectomy in this patient is a better treatment option than MRM, although a blanket statement for unsafe CSOM treatment of choice is MRM, but in such patients radical is a better treatment. I hope that sounds good and logical to you. Fifth question, another one. A driver by profession has reported to ENT OPD with vertigo. The patient experiences vertigo mainly when he turns his vehicle on the road crossings. In the crossing, sometimes you turn the vehicle. That is the time the patient experiences vertigo mainly. No hearing loss, ear discharge or tinnitus, no other complaint. This is the only complaint, vertigo, especially when the patient turns the vehicle. Pulse is normal, BP is normal, respiratory is normal, otoscopy is also, tympanic externally, everything is normal. Tuning fork and audiometry were also normal. So which are the following investigation or test is the most important in this test? So the only complaint, positive thing is the patient has vertigo, which is essentially when the patient is turning the vehicle. So we don't know what is the diagnosis. So how do you confirm the diagnosis? They say. So what do you suspect first thing? Based on that, you know which is the best investigation in this patient. Is it electrocochleography? Is it tympanometry? Is it caloric test? Is it Dix Hellpike maneuver? So which is the test? And first you have to know from the history what is the likely diagnosis. What is your differential diagnosis in the first place? Based on that, you have to confirm by doing any of these investigations. So what is your answer? Your time is ticking. What are you suspecting in this patient? Vertigo, which is mainly when the patient is turning the body. When you're turning your vehicle, your body also turns, your position changes. It is Bppv. This is a very typical history of benign paroxysmal positional vertigo. We all know Bppv stands for benign paroxysmal positional vertigo. Do you want me to write this name? Benign paroxysmal positional. See this word positional vertigo is when the patient changes the body position. When the patient turns, the body turns and the body position changes, and then the only complaint is vertigo, which is true here. No other complaint, no other finding. But we have to confirm this. So which is the confirmatory maneuver for Bppv? We all know. Dix Hellpike maneuver, I'm sure everybody knows, is a confirmatory maneuver almost for Bppv. So you do this maneuver and look for nystagmus. If the patient begins to have nystagmus after doing this maneuver, it's a positive test. That means that goes in favor of Bppv. And on doing this maneuver, if there is no nystagmus, that it is a negative test, means the patient may not be having Bppv, right? Electrocochleography is done for Meniere's disease. When you suspect Meniere's disease, it's investigation of choice sort of. For Meniere's disease, either you can do electrocochleography or you can do MRI also. MRI can actually show the high drops. We all know there is high drops in this patient. Tympanometry is done for middle ear disease. And in middle ear disease, vertigo is a very uncommon thing. Hearing loss and discharge and pain are the main things. Hearing loss, discharge, pain. No vertigo actually. And this patient only vertigo, so it cannot be a middle ear disease. It has to be inner ear disease. Caloric test can be done in this patient because caloric test also checks the vestibule. But between caloric test and Dix-Hallpike test for Bppv, Dix-Hallpike is definitely a better investigation. And that's why we go for this one. In Bppv, the vertigo is very short lasting. Short lasting vertigo less than 20 seconds. That's why the term paroxysmal means very short lasting. And there is a treatment called Apley's maneuver. Apley's maneuver is done as a treatment for Bppv. And these are simple points and they are very common points that most people know them already. But these are the things they ask in the exam. You can't ignore, you can't take them for granted at times. They can twist and turn the same thing and try to confuse you. The exam is all about not only testing your knowledge, testing your application of the knowledge and your status of mind in that, those 3 hours. How anxious you are you able to use your knowledge? Some people, they have read everything they know, but in the exam, they just cannot answer because they get very nervous. So all that is a test. And this is what your examiner is testing. Next question. A 40-year-old lady presented with bilateral ear discharge off and on and deafness. Discharge is off and on and there is deafness. No vertigo, tinnitus, bleeding, etc. No other systemic problem. Everything else is normal. Vitals are within normal limit. On otoscopy, both the tympanic membrane has central perforation with ocular damage. No polyp, no granulations. After investigation, both the ears were operated. Bilateral tympanoplasty was done because both were problem. On right side, tympanoplasty type 3 was done. On left side, tympanoplasty type 1 was done. Few months later, the patient came back for follow-up and Weber's test was done. Most probably, what will be the Weber's finding in this patient? Lateralized to the right side, lateralized to the left side, centralized, or Weber's should not be done. So again, it's a very nice question. It's not a very difficult question, but what's your answer? That's the most important thing. Is it A, lateralized to the right side, B, lateralized to the left side, C, centralized, or Weber should not be done, which is the D choice? What do you think? So again, you have to make a diagnosis and then treatment that about tympanoplasty. This is basically about tympanoplasty. Now, the answer is, let me check first. On the right side, type 3 was done. So it will go to the right side. A is the correct answer. It will lateralize to the right side. Now, actually it is about tympanoplasty. The rest of it is just to make it look like a clinical question. It's an adult lady, bilateral discharge off and on. Remember I just told you non-continuous discharge. Non-continuous discharge here, off and on, is safe CSUM. So this patient is, from the first line, we get an idea that this patient must be having safe CSUM because the discharge is off and on, not continuous. It is non-continuous discharge. And deafness, in CSUM definitely you'll have deafness. And there is no bleeding, see. So it is not, perhaps not an unsafe CSUM. We just discussed unsafe may have bleeding also. And no tinnitus, no vertigo means there is no inner ear problem. It is only a middle ear disease. And there is no other systemic disease. Okay, vitals are normal. Now bilateral central perforation. I just told you central perforation, which is past tense of perforation, are safe CSUM. So it is bilateral safe CSUM. We know for sure by now because there is central perforation and some muscular damage can happen in safe also, right? And no oral polyp, no granulation. Polyp and granulations are mainly seen in unsafe CSUM. This again proves this is safe CSUM. And if you remember, I told you in safe CSUM, you can do meningeoplasty or tympanoplasty. In this patient, because the ossicles were damaged, also you have to do tympanoplasty. So tympanoplasty was done in both the ears, but right ear it was type 3 and left ear it was type 1. So Weber's will lateralize to which side? Now we all know tympanoplasty type 1, type 2, type 3, type 4 and type 5. There are 5 types of tympanoplasties. Type 1 has all the 3 ossicles left in the middle ear. Type 2 has only 2 ossicles left in the middle ear. Type 3 has only 1 ossicle left in the middle ear, and type 4 has 0 ossicle left in the middle ear. Normally, naturally we have 3 ossicles. So when you do type 1 tympanoplasty, you are creating a same situation as nature has given you. It's a natural form, so the hearing is very good, right? So left ear has a very good hearing because it is type almost nearly normal. Type 3, the hearing cannot be as good as type 1. See, this is the best situation, and as you keep going down, this is the worst situation. Type 4 has the worst hearing. That's why we try to do type 1, because that gives the best hearing. Type 2 is little less than type 1. Type 3 is little less than type 2. Type 4 is little less than type 3. So type 3 tympanoplasty will have some hearing loss, but we do not have an option. That's why we have to do type 3. What is the hearing loss in middle ear disease? Conductive hearing loss. So this tells you that if you have done type 1 tympanoplasty in left ear, which may not have any hearing loss, may be normal, or even if there is a hearing loss, it is very mild conductive hearing loss after the surgery. But left ear, which is type 3, has some hearing loss, conductive hearing loss, because it is type 3 tympanoplasty, only 1 ossicle. 1 ossicle cannot be as good as 3 ossicles, isn't it? Amplification cannot be that good. So left ear definitely has some conductive hearing loss, and in conductive hearing loss, left ear has type 3. Okay, right ear, sorry. In the right ear you have type 3. So right ear has conductive hearing loss, left ear is nearly normal. In conductive hearing loss, Weber's goes to which side? In conductive hearing loss, Weber's goes to the same side as disease. That's why, because right ear has type 3 tympanoplasty, so right ear, because of type 3 single ossicle, there is some conductive hearing loss, and that's why the Weber's will go to the same side in this patient. That's why it is lateralized to the right side. Okay, so this is about tympanoplasty. Now, why do we have 4 types of tympanoplasty? 5 actually, type 1, type 2, type 3, type 4, because depending on the situation, we have to end up doing type 1, type 2, type 3, or type 4, or type 5. Which is the best option? Best option is type 1. Why? Because it gives you the best hearing, but you need all the 3 ossicles intact. But sometimes if all the 3 ossicles are not intact, 1 or 2 ossicles are damaged, then those ossicles has to be removed, and you end up doing type 2 when there are 2 ossicles, or type 3 when there is 1 ossicle, and type 4 when there is no ossicle. So it depends on the situation. But if you do type 2, then the hearing is not as good as type 1. If you do type 3, then the hearing is not as good as type 2 or type 1. If you do type 4, then the hearing is not as good as type 3 or type 2 or type 1. So if you do type 3 in right ear, the hearing is not normal, at least it is less than normal, and it is conductive hearing loss in the right side. In the left ear you have done type 1, which is nearly normal. So you assume that left is normal because type 1, right is not normal because type 3, it is conductive hearing loss. In conductive hearing loss, Weber's goes to the same side or disease side. That's why in the right side. I hope that's clear, right? So it is asking you 2 things. It is asking Weber's, in CHL it goes to which side, and it is asking you about tympanoplasty a little bit also, right? Next question. A 60-year-old gentleman presented with vertigo for few days. No deafness or tinnitus, only vertigo. Elderly person, vertigo, and few days history. He is non-diabetic, non-hypertensive. He gives history of sore throat a week back, for which he was treated by his family doctor. Sore throat, cold. Vitals are normal, otoscopy is normal. Everything looks normal. Tuning fork and audiometry is suggestive of normal hearing, so he has no hearing. The only complaint is hearing loss. There is no other finding. He had a sore throat a week back only. That's the only which was treated. MRI of the temporal bone is also normal. Likely diagnosis: acute suppurative vertigo media, Meniere's disease, suppurative labyrinthitis, vestibular neuronitis. So what is your correct answer? elderly person, only vertigo few days, passage of sore throat, no other symptom, no other finding. That's what it says. Hearing is normal. And the answer is vestibular neuronitis, D. Actually, this is a very typical or a classical presentation of a vestibular neuronitis. Vestibular neuronitis is seen in elderly, only vertigo, so no hearing, no, only vertigo, and it's an infection of the vestibular nerve. See, neuronitis means inflammation of the nerve, it's not vestibular nerve. So infection is caused by herpes simplex virus. So this is actually a herpes simplex virus infection of the vestibular nerve in elderly person, right? And the only complaint is vertigo. Now vertigo in this patient remains for few days. Like in Bppv we discussed, the vertigo remains only for few seconds. It's a paroxysmal vertigo for a very short duration, I told you. In Meniere's disease, the vertigo remains for more than 20 minutes. And in this patient, neuronitis, the vertigo remains for few days. So see, vertigo for few days. This is a very important uh, information in this question, few days vertigo. So once again, in Bppv, the vertigo is less than 20 seconds, just seconds. In Meniere's, it is more than 20 minutes to 24 hours, less than 24 hours. And in vestibular neuronitis, it is for days, few days, maybe a week or so. And that's why in all my lectures, I always tell you that duration of vertigo is very, very important in ear diseases. You should, when the duration of vertigo is given, you should always be mindful of that fact. You should always note that thing because it gives you a very important lead towards the diagnosis. Like these three conditions, you can know from the duration of vertigo also. So even if you do not know anything, if you know this fact that vertigo for few days is very important in vestibular neuronitis, then it could have given you a very strong lead towards the diagnosis. And in vestibular neuronitis, very importantly, as I said, it is caused by herpes simplex virus. It's a viral infection of the vestibular nerve. That's a vestibular neuronitis. But where does the virus come from? The virus comes from the throat. So this patient usually have a throat infection 1 to 2 weeks back, which is also given here. So this is another very, very important clue that you have. A week or 2 week back, the patient has throat. So elderly person having sore throat followed by vertigo after 1 or 2 weeks, very strong suggestion of vestibular infection by the herpes simplex virus. And vertigo is going to be the only complaint, no hearing loss at all. This is very, very important. This is one of the few conditions where hearing loss is absolutely not there. So all your tuning fork, audiometry, all the hearing tests will be normal. But if you do vestibular function tests like caloric test and all that, they will show you positive finding. Hearing test will be normal, vestibular function test will be abnormal because it is vestibular problem. It is not ASOM because ASOM has pain, discharge, we all know, and there is no vertigo. In ASOM there is no vertigo. Is it middle ear disease? I told you no vertigo usually. Meniere's disease will always have hearing loss. This is the main complaint. Meniere's disease, vertigo, hearing loss, and tinnitus. And vertigo is not for days in Meniere's disease. Certainly not. One day maybe, but not for days. Certainly not. And they will have definitely tuning for audiometry finding will show you some hearing loss, sensory neural. Same is the case of labyrinthitis. Suppurative labyrinthitis, again hearing loss is the main complaint. Main problem in suppurative labyrinthitis, infection of the inner ear, is vertigo. Main complaint is hearing loss and some pain because it's a suppurative disease, it's an inflammatory disease, so there is a pain also. Vertigo may be there, and vertigo in this case can also last for days because till the infection is there in the labyrinth, the vertigo can remain, but only vertigo is not the symptom. Definitely hearing loss, definitely pain in this patient, and therefore there is no doubt that this patient is suffering from vestibular neuronitis. Clear? Next question. And vestibular neuronitis is only symptomatic treatment. It's a viral disease, and we all know viral diseases have tendency to have a shelf life. Few days they remain and then they disappear. The same is going to happen to this patient. Once the virus disappears, the patient will become normal, but till then you have to give anti-vertigo and bed rest. Obviously, if you have vertigo, you can't go out. You have to be on the bed, and you have to give anti-vertigo drug to control that vertigo till the patient has symptom, which is going to last for few days, maybe a week or two, right? Days vertigo. The next one, A young college student has meningitis, following which she had hearing loss in both the ears. Because inner ear and the neural ear remains in the cranial cavity, so when you have cranial infections, it is very common to have inner ear and the nerve involvements causing hearing loss in both the ears. There is no other complaint. There is no significant finding on examination. Audiometry was suggestive of severe sense hearing loss in both the ears. Further investigation showed increased latency between first and the third peak of BERA, and also low speech discussion score. So besides hearing loss in both the ears, there's increased latency between the first and the third peak of BERA, and there's low speech discussion score. The patient was prescribed hearing aid because hearing loss in the inner ear. Because how do you know inner ear? Because meningitis causing hearing loss cannot be middle ear. It has to be inner ear. That's why hearing aid was prescribed, and the finding is normal, as it says. All the findings are middle ear. Findings are never normal. If you have disease in the middle ear or external ear, then the findings are never normal. There is going to be some positive finding. Inner ear you can't see. That's why normal findings are usually there. But with hearing aid, there is no significant improvement. So which is the next best option? Brainstem implant, cochlear implant, bone anchored hearing aid, any of the above can be given. So what is your answer? I've also discussed few things while I was reading this question, so you might have got some idea as to what is this. Now, as I said, this is not a middle ear disease causing hearing loss. It is inner ear disease, either labyrinth or the nerve, because it is due to meningitis, and it's bilateral. That's why it's bilateral. Same brain, both the sides in this brain gets infected. Now, whenever you have hearing loss of sensory neural in nature, this has to be sensory neural hearing loss because inner ear. One of the things we often do is we prescribe hearing aid. Now, in this case, the hearing aid did not work. So you have to go for something else because there is a severe hearing loss, as it says, severe hearing loss, so sometimes it does not work. Especially if it is a neural disease. Eighth nerve diseases, hearing loss are not very good options. But is it cochlear disease or neural disease? We know this from these two findings. See, BERA latency is increased and there is low speech discussion score. Both point towards retrocochlear disease. Now this is a retrocochlear disease causing hearing loss, or you can say neural hearing loss. Eighth nerve is damaged, that's why there is a hearing loss. And this also is proven by the fact that hearing aid is not benefiting. You know, in cochlear diseases, usually hearing aids are very beneficial. But in a retrocochlear disease, hearing aids are not very beneficial. And this is proven by. So there are so many things telling you that it is a retrocochlear disease, eighth nerve disease. And if eighth nerve disease, if everything else fails, the only other option is brain stem implant. Because eighth nerve comes from the brain stem pons, so eighth nerve is damaged, you have to go beyond that, proximal to that. So you go to the brain stem in the pons and you implant there. So that's called brain stem implant. If it is a cochlear disease, then you do a cochlear implant. If the neural disease is brain stem. So brain stem implant for neural disease and cochlear implant for cochlear disease. Baha is used for, again, middle ear or external ear disease, where normal hearing aid do not help. If a normal hearing aid do not help, but due to middle ear or inner ear, external ear disease, then Baha can be used. In Baha, cochlea and the eighth nerve has to be normal. If you want to use Baha, cochlea and eighth nerve has to be normal. Only then Baha is useful. But here the nerve is damaged, because how do you know nerve is damaged? BERA latency is increased and low speech discussion score, right? So this tells us that you have to know how do you differentiate a cochlear disease from retrocochlear disease. There are so many features like recruitment, short increment sensitivity index, autoacoustic emission, BERA, speech discrimination score, low then roll over curve, tone decay phenomena, stapedial reflex, acoustic reflex. There are so many investigations that can differentiate between cochlear and retrocochlear disease. If you don't know about this, go back to my lectures and just try to see those parts. I've explained very beautifully there. But they're very important things for these kind of questions. They can ask you these kind of questions. So you have to be knowledgeable about these things, cochlear versus retrocochlear disease, all the important investigations. Right. Next one. A 55-year-old man presented with deafness and tinnitus in the right ear for few months. He says that he has sudden attack of vertigo, following which the deafness and tinnitus improves. There is no other significant symptom. Reniz is positive in both the ears and Weber's is lateralized to the left ear. Further investigations are pending, most likely diagnosis. So, what is the is it Meniere's disease? It is acoustic neuroma, suppurative labyrinthitis, or superior canal dehiscent syndrome. So it's a middle-aged male. Only this vertigo and tinnitus, deafness and tinnitus for few months. But this hearing loss and tinnitus improves after an attack of vertigo, episodes of vertigo. Now this is a very typical history of Meniere's disease. This first sentence, 2 sentences will tell you it is Meniere's disease. This is a very, very typical of Meniere's disease, where the patient begins to have tinnitus and hearing loss, and then there is a sudden attack of vertigo, and the hearing loss and tinnitus improves following that. And that's why the tinnitus and hearing loss is called fluctuating. They will improve and then start. That's why there is a fluctuating hearing loss and fluctuating tinnitus in Meniere's disease. And these are attacks of vertigo, means episodes of vertigo. So fluctuating Meniere's, fluctuating hearing loss, fluctuating tinnitus, and episodes of vertigo are a very typical finding of Meniere's. Straight away you know it is Meniere's disease from this, right? And there is no other symptom. And Reniz is positive in both the ears, and Weber's is lateralized to the left side. In this, the deafness has to be sensitive neural hearing loss, because it is Meniere's disease we are suspecting. And in sensitive hearing loss of the right ear, Weber's will go to the opposite side. In SNHL, it goes to the left side. But Reniz is positive in both the sides, because one is normal, one is SNHL. And Reniz is positive in normal as well as SNHL and normal, both give you positive Reniz. So because one is normal and one has SNHL, that's why Reniz is positive in both the ears. But Weber's will go to the normal side, which is left side in this case, because the right side has a hearing loss, right? So Meniere's disease. Acoustic neuroma does not have this fluctuation and episodes. They may have acoustic neuroma may have these 3 symptoms: deafness, hearing loss, and tinnitus, but it is continuous. There is no fluctuation, there is no episode. Same is for all the 3. All the 3, there is no fluctuation. It is continuous problem, right? So that tells you it is a Meniere's disease. But again, you have to confirm with either MRI or electrocochleography. So to confirm Meniere's, either you do MRI, which will show you the hydrops, as I said, or you can do electrocochleography. Both can be done. Whichever is given the choices may be the correct answer. But next question. A patient presented with right-sided facial nerve palsy. All the investigations were normal, and so the diagnosis of Bell's palsy was established. We all know Bell's palsy is idiopathic facial nerve palsy, where there is no cause of facial palsy found. So because there was investigations are normal, so Bell's palsy. The patient was put on steroid for few weeks with physiotherapy and acyclovir. This is the treatment for Bell's palsy that we gave. After 3 weeks of this treatment, there was no improvement, and so a surgical decompression was planned in this patient. This is a very typical management that we do in Bell's palsy. But we first give steroid, mainly steroid. Rest of the 2 are optional, that is physiotherapy and acyclovir is optional. But anyways, it was given here, but there is no improvement. So the next line of treatment is surgical decompression of the facial, and that was planned. So this is a very classical management for this kind of patients. But look at the other. On further investigation, the patient was found, the following was found: reduced taste on the same side, absence of acoustic reflex on the same side, normal lacrimation on both sides, reduced salivation on the same side. So surgical decompression should be carried out on which part of the facial? They are asking you, with this kind of finding, which part of the facial nerve has a disease or the problem, so that you can compress distal to that area. Is it labyrinthine part, horizontal part, vertical part, or at the stylomastoid foramen? So what is the correct answer? This is a very conceptual question. It is basically anatomy of the facial nerve and these branches. And these tests that we have done, they are all called topodiagnostic test. If you have do not know about all this, then again you have to attend the lecture. where these are done in great details. I tell you everything about this. Topodiagnostic tests in facial palsy are done to locate the site of the problem. So we have to know the site of the problem so that we can do a problem decompression that site on that site. So now I'm sure you know that the only normal finding is lacrimation. It is normal. Everything is reduced. So that means the branch that goes and supplies the lacrimal gland, till there it is normal. And this is your first branch of your facial nerve. I'm sure you know the first branch of the facial nerve, which is called greater petrosal nerve. Greater petrosal nerve. This supplies lacrimal gland, and this is normal. So till here everything is normal. This is labyrinthine part of the facial nerve. So till labyrinthine part everything is normal, and after that everything is abnormal. All the three tests are reduced. So you have to go distal to the labyrinthine part, and distal to the labyrinthine part is the horizontal part, right? So if I draw the facial nerve, see the facial nerve comes from the pons I told you, then the facial nerve goes like this and takes a turn, and then goes like this, and then it goes to the parotid gland where it divides into 5 branches, right? So this is the geniculate ganglion. And this is in the labyrinthine part. So this is a labyrinthine part. From here the first branch arises, lacrimation. So till here everything is normal because lacrimation. So the problem is after that the second branch, which is for stapedial reflex, it comes from here. So this is already gone, taste and all are all gone. So the problem lies between these two areas, because this is normal and this is abnormal, this is normal, this is abnormal. The problem has to be between those. This part is called the horizontal part. So in this particular patient, horizontal part is the part which has a problem, because after, if it is here damage, so this much is normal and this has a problem because the signal is coming from the brain. That's what it means, right? Although usually if I ask you which is the most, if I do not give you all this, and if I ask you most likely which part has to be decompressed, then it is labyrinthine part, because most of the time the compression is in the labyrinthine part, because labyrinthine part is the narrowest part of the facial nerve. But this is not about that. This is based on the topodiagnostic test. You have to make a diagnosis that which part of the facial nerve has a compression, so that you can go to that particular part and do the decompression of the facial nerve, which is horizontal part. So you have to know the anatomy of the facial nerve, and because this is just a like a question answer session, we cannot discuss the anatomy of the facial nerve in great details. But if you want to know the details of the facial nerve and how do you arrive at this conclusion, then of course you have to watch the class video. You have to attend the lecture for that. Okay, now this is all. We have done 10 questions today in this session, and they were all clinical based questions from the ear. In part 2, I told you I will talk about, we'll take questions from throat and nose, so please watch out for that. We are going to have similar kind of session, very informative questions, very helpful to improve your concepts. But before I leave you, I must tell you about the courses we told you in the beginning also, that we have focused NEET PG for 2022, which already began in August. The ENT starts on the 14th of December. It's going to be a 30-hour class of ENT. Everything is going to be discussed there. So please join if you have not joined that. This iconic subscription, everybody knows about this. Very common among students. Students are really loving this combination. So please check out. And this is a marathon batch for MCQs. In a very short duration of time, we are going to take all the 90 subjects and questions from each topics. ENT starts on 30th of November. Total only 5 hours. 5 days, 1 hour session each, just 5 hours, and ENT will be done. So very, very useful for last moment revision, those who are planning to write NEET PG 2021. Very, very helpful. So never must join if you are not joined it. So with this, I'll take a leave, and thank you for joining this session. Wish you all the best for your future, and look out for part 2 of ENT. God bless you.